This is our first grand rounds for trauma critical care for this year. I'm very lucky to have Dr. Saus speak to us about a topic that we don't have to deal with very often, but when we do, it's a real problem and something I have to admit I know very little about. So, Jay.
Thank you. I guess Dr. Weigel asked me to speak about a very hot topic. First of all, let me say I certainly appreciate the invitation to come to Surgery Grand Rounds today and speak with you about this. Malignant hyperthermia is a big concern for anesthesiologists, and I'm sure it's a big concern for surgeons as well. This is an area in which, if it happens, we need to work together very well, very efficiently in the operating room. But let me start getting into some of the presentation about this and then tell you about it. First of all, malignant hyperthermia is clearly a life-threatening pharmacogenetic disorder. It's triggered by administration primarily of volatile anesthetics, but also succinylcholine. And malignant hyperthermia is a hypermetabolic crisis that, if untreated, is fatal. It's a genetic problem. Individuals who possess the genetic mutations are designated as MH susceptible or having MH susceptibility. As I mentioned earlier, fortunately it's very rare. We don't see it often. Unfortunately, however, it may be very difficult to recognize when you're in the early stages of it. The signs and symptoms often are deceptive, not only to the surgeons, but especially to the anesthesiologist. The increase in end-tidal CO2 is often the first thing that you see, but this may be gradual. It doesn't necessarily happen immediately. The end-tidal CO2 may only increase by a few torr every minute. And it may be inadvertently disguised because the anesthesiologist or nurse anesthetist sees a little bit of an increase in carbon dioxide, and so we compensate by increasing the minute ventilation. And then a little later, as a little higher end-tidal CO2, you compensate by increasing the minute ventilation. And so the temperature increases that we always think about with malignant hyperthermia may actually not be present for 30 to 60 minutes or even longer. The muscle rigidity that goes with malignant hyperthermia also may be disguised by the anesthesia medications we use, such as the muscle relaxants. Myoglobin is released from damaged muscles. Myoglobin is then cleared by the kidneys and appears in the urine, but that may take quite a bit of time before that sign is obviously present. In malignant hyperthermia, it may be that the first indication of malignant hyperthermia actually occurring is just that the soda lime canister that absorbs the carbon dioxide in the anesthesia machine becomes exhausted rapidly, and sometimes the soda lime gets pretty warm, but the problem is that that's often not recognized because typically the anesthetist or anesthesiologist does not have their hand on the soda lime realizing it's getting hot. There is no temperature detector in the soda lime to show that it's happening. Typically what we will see is just the soda lime, instead of staying nice and white, may be turning blue more rapidly than you expect that it should. So here's an example of an MH case that was somewhat deceptive. One of the things that made it deceptive was that it was a morbidly obese patient who was 5'3" and 149 kilograms who was having a tympanomastoidectomy. Induction of general anesthesia really was not very noteworthy. It was just a plain old straightforward, give a little bit of midazolam, give fentanyl, propofol to put the patient to sleep, succinylcholine for muscle relaxation for intubation, and that looked fairly straightforward despite the morbid obesity. It really was not that much of a challenge to intubate the patient. The end-tidal CO2 then increased to 84 over the next 30 minutes, and what was a sinus rhythm initially changed to sinus tachycardia. The patient's axillary temperature was 35.9 to 36.1 at this point. Now, I can't tell you why an esophageal temperature probe or a nasal temperature probe was not used. However, the temperature monitoring for the patient was strictly an axillary temperature monitoring. So when this happened, the initial response of the nurse anesthetist was to increase the ventilation to 6,500 cc's a minute when ventilation started at 6,000 cc's a minute. But then over the next 15 minutes, the end-tidal CO2 kept climbing to 114 instead of the around 40 as we would expect. So the minute ventilation increased to 12,300 cc's per minute. Initially, this dropped the CO2 a little bit to the 80s, but then the CO2 started climbing again, and over the next 15 minutes, ventilation, as it kept increasing to 14,300, the end-tidal CO2 remained in the 110 to 120 range. They tried manually ventilating, just to be sure that there wasn't a problem with the ventilator itself, and noted that the lungs felt a little tight. So they said, well, gee, maybe the lungs are feeling tight because she's having a little bit of an asthmatic reaction to the isoflurane, and so they changed to sevoflurane to try to see if we could increase a little more bronchodilation. And in an additional 30 minutes, the note was that the lungs were very tight to manual ventilation, and so let's give a bronchodilator and put 4 puffs of albuterol inhaler into the endotracheal tube. Approximately 90 minutes after anesthesia induction, we finally see an axillary temperature reaching 38 degrees C, and the end-tidal CO2 was 120. So with the end-tidal CO2 getting that high, another thought was, well, gee, maybe we've got a problem with the gas sampling line, maybe there's a problem with the water trap. So all of the things checking out the anesthesia machine were changed to put a new sample line in, put a new water trap in, and guess what? That didn't help. The end-tidal CO2 still remained high, and at this point there was a call for the faculty member to come see what was going on and see if they could help, and pretty much quickly realized what was going on, that this was a malignant hyperthermia case rather than a machine malfunction. So we started dantrolene administration, and the temperature was 38.9 degrees C when the dantrolene was started, and continued rising to a peak of 41.3 degrees over about the next 15 to 30 minutes, which was just over 2 hours into the surgery case at this point. So let's talk about the pathophysiology of malignant hyperthermia. You have to understand muscle contraction really first to get a really good feeling of understanding of what malignant hyperthermia is all about. So we know that the primary determinant of muscular contraction is calcium in the cytoplasm of skeletal muscle cells. In the baseline relaxed state, the calcium that's intracellular is sequestered within the sarcoplasmic reticulum of the cell. When the muscle is stimulated by an impulse, this depolarization leads to activation of dihydropyridine receptors on the muscle cell membrane, which in turn activate the ryanodine sensitive calcium channels on the sarcoplasmic reticulum to allow a greater amount of calcium into the cytoplasm of the cell. So this increased cytoplasm concentration of calcium activates the actin-myosin to produce skeletal muscle contraction. So that's a lot of words that may sound complex, but let's kind of take a look at the picture of it. What's really happening is you start with an action potential that comes to the cell, opening the dihydropyridine receptor, so some calcium from the cytoplasm goes into the cell. This in turn activates the ryanodine receptor. It's almost like pulling a plug out of a container. So the sarcoplasmic reticulum has most of the intracellular calcium sequestered in this area. You pull the plug out, more calcium rushes out, which then activates the actin and myosin to cause the muscle contraction. Normally, this is a very quick response. The ryanodine receptor opens and then closes back. The defect in malignant hyperthermia is that the ryanodine receptor, almost like this plug, doesn't close back up. It stays open, allowing more and more potassium to rush out of the cell. More and more potassium rushing out of the cell causes continued constriction of the actin and myosin causing muscle action. That continued muscle action in turn generates heat. So when, as I just mentioned, when the stimulus is terminated, the ryanodine receptor closes, calcium then becomes resequestered from the cytoplasm back into the sarcoplasmic reticulum by specialized calcium pumps. Muscle contraction stops. The problem is in some individuals they have an inherited defect in this mechanism. So the ryanodine sensitive calcium channel receptor or defect in other proteins associated with this leads to the sustained release of calcium from the cell, as I mentioned to you in a minute ago. We get the muscle action, we get the sarcoplasmic reticulum channel, the ryanodine receptor channel closing, muscle contraction stops, and that's it. The sustained muscle contraction, though, however, leads to the hypermetabolic state, excess lactate production, excess carbon dioxide production, excess heat production, excess consumption of ATP, excess consumption of oxygen. So ultimately, the ATP depletion causes failure of the cellular homeostatic mechanisms. The cell fails irreversibly, and this is what leads to so much problem. When the cell fails, then it does not hold the stuff inside that's usually there, so you have a big release of creatine kinase and myoglobin from skeletal muscle cells into the bloodstream. So what do you have that happens with that? Well, hyperkalemia, hypokalemia, rhabdomyolysis, arrhythmias can occur, end organ damage can occur, and if you don't recognize it and treat it, eventually this leads to death. So an MH trigger, an episode of MH typically requires an underlying MH genetic susceptibility and the presence of a triggering agent. The triggering agents usually are inhalational anesthetics and succinylcholine. Rarely in humans, stress can cause a malignant hyperthermia episode, but this is actually seen more often in certain breeds of pigs. In fact, that's sometimes laughingly referred to as the self-roasting pig. And the pig has been used in a lot of the MH research because they can get the MH happening without requiring an exposure to anesthetic first. So it gives them a way of studying it much better. So we talk about what does trigger MH. What we also should look at is what does not trigger MH. Therefore, what drugs are safe to use in surgery when you've got a known MH patient or if MH occurs when you're not expecting it. So here are some agents that do not trigger MH. Of the inhalational anesthetic agents, oops, sorry, hit the wrong button again. Of the inhalational anesthetic agents, nitrous oxide is the only one that we know does not trigger malignant hyperthermia. So it's safe enough to continue a nitrous oxide and an opioid type of technique for continuing anesthesia when we have to stop using the anesthetic MH triggers. A lot of the IV medications of various structures and various chemistry do not trigger malignant hyperthermia, so they're safe to use. Benzodiazepines like midazolam, Versed, Valium, lorazepam do not trigger MH. Local anesthetics are safe. All of the opioids, the fentanyl, sufentanil, L-fentanyl, remifentanil, morphine, all those drugs are safe to use in patients with malignant hyperthermia. The only muscle relaxing agent that is a problem is the depolarizing muscle relaxant, succinylcholine. The non-depolarizing muscle relaxants are not a problem with malignant hyperthermia. Malignant hyperthermia has a variable expression, and this is one of the tricky things, is that sometimes a patient may go through a general anesthetic with an inhalational anesthetic and not trigger malignant hyperthermia and come back for another surgery maybe a few years later, and it will trigger the malignant hyperthermia. The reactions are actually more common in young people and in males, but there is no ethnic or geographic predominance. Another deceptive part of this is that the time of symptom onset does not necessarily have to happen immediately with initial exposure to anesthetic. Following a successful treatment, approximately 20% of patients can experience a recurrence if they come back to surgery at a later time or later date. So anyone who has had a malignant hyperthermia episode needs to be very aware of that, and there needs to be notification of the medical personnel taking care of that person for any subsequent surgery. And as the note at the bottom says, actually this may be more common in people who have a greater muscle mass than those who have less of a muscle mass. I alluded to this earlier, but the MH crisis is likely to be fatal if left untreated, and the morbidity can be serious even if it is not fatal. Non-cardiac complications, non-fatal complications occur in about 35% of patients, and you see there's a lot of problems that certainly can occur of cardiac, kidney, renal, hepatic dysfunction, coma-induced, pulmonary edema. And one of the big ones to fear, of course, is if DIC starts happening in the middle of surgery. Initial symptoms can vary. As I mentioned earlier, the most reliable initial symptom is a increased production of carbon dioxide, increased rate of exhaustion of the CO2 absorber, but that you've got to be looking for it, basically, to see that happen. Sinus tachycardia, masseter muscle spasm, of course, occurs, and just generalized muscle rigidity may occur, and sometimes the muscle rigidity will be noted even despite the use of muscle relaxants. It's typically much more difficult to see with a depolarizing muscle relaxant than a non-depolarizing muscle relaxant. Hyperthermia, the herald of malignant hyperthermia, the high temperature or increased temperature does not happen early. It does not happen initially, or at least it's not usually recognized early. It may be absent when the diagnosis is suspected, and it may be a very rapid increase in the temperature from the very beginning. It's a variable sign. The sustained muscle contraction, because of the unregulated calcium release, generates a lot of heat. The hyperthermia can occur within minutes of starting surgery. It can occur much later. The rhabdomyolysis of skeletal muscle and cardiac muscle can occur, and plasma CK and urine myoglobin levels can peak much later. It's not going to necessarily peak immediately when this starts. Brownish or tea-colored urine is the thing to look for to see if there's a presence of myoglobin, if you're not just measuring lab values. Now, I've talked about muscle damage, rhabdomyolysis, tea-colored urine, increased plasma CK, myoglobin present. So ask the residents, does this look like anything else you know of? Any ideas? Greg? I'll put you on the spot. What else can look like this?
I mean, if you've got rhabdomyolysis from another cause, like positional injury or something.
Okay. Well, what else can this look like? How about heat stroke? You can have these same kind of things happen with heat stroke, or an exercise-induced rhabdomyolysis, and that's why I called on you, Craig, because I knew that you just participated in a 5K run yesterday. So all these things can happen just from muscle damage and may look a lot like malignant hyperthermia. So the question is, if someone has experienced heat stroke or rhabdomyolysis, does that mean they're susceptible to malignant hyperthermia? should they be tested for malignant hyperthermia? Well, the answer is really not clear. Both of the answers to those questions are controversial, and the best answer is, well, maybe. The current best advice is, yeah, if somebody has experienced this and there's any thought about them undergoing anesthesia, it might be good to go ahead and have a caffeine health and contracture test performed, and if that's positive, then undergo genetic testing. So, muscle breakdown from lipid-lowering drugs can also cause muscle damage, from the statins especially. We know that's a side effect of statins. Serotonin syndrome can cause muscle breakdown. Neuroleptic malignant syndrome can cause muscle breakdown. However, after studying this for years, the conclusion is that these really are not associated with malignant hyperthermia at the genetic level, and therefore, in these conditions, it is not recommended to have someone tested for malignant hyperthermia. So let's get back to the case that I talked with you about earlier, about when we actually had the malignant hyperthermia happen. Well, here's some lab values. The interesting thing is that the respiration, the ventilation and oxygenation was managed so well that at the end of the case, the blood gases really were pretty normal, so I didn't even bother to try to put those on a slide for you. But look what happens here with, well, if I can stay on the same slide, CK. Look at these levels. Have you ever seen levels of creatine kinase like this? Look at the myoglobin. 26 hours later, there's a lot of myoglobin in the urine. Alkaline phosphatase increased a little bit in the beginning, but then settled back out pretty quickly. GFR, kidney damage here, but it again tended to resolve within a few days. In this case, what actually happened with this patient is malignant hyperthermia was recognized, the case was aborted. These were the levels at even about 4 days later. After about 6 months, the patient came back for the same surgery, had the surgery completed using totally non-triggering agents, and it went fine. By the time the patient came back a few months later, all lab values had returned to completely normal. So the severity and timing of other signs of MH can vary and depend on the extent of muscle mass involvement. So we've talked about a lot of these already. EKG changes, you might see peak T waves, PVCs, VTAC or VFib. The severe hyperthermia does tend to be associated with DIC, especially if malignant hyperthermia is not treated early. And unfortunately, DIC is a poor prognostic indicator and is often the terminal event in an MH patient if it is not caught early and treated. There is another condition that's associated with malignant hyperthermia called central core disease. It's an inherited, very rare autosomal dominant disorder. Manifestations are pretty variable. Typically, a patient with central core disease is recognized even in infancy because the kid just, after delivery, just seems a little floppy. This affects the skeletal muscles. It tends to affect the more proximal muscles, so upper legs and hips. Some patients may not even have much noticeable change with central core disease, so it seems to have a variable penetrance. It may be very severe. Most people who have this experience a mild muscle weakness, and the key is that mild muscle weakness does not get worse as time goes by, unlike many other muscle problems that tend to be gradual in the beginning and then get worse and get worse. Central core disease is typically a lifelong thing that does not get any worse. And it's associated because the same allele on the genes carries the central core disease as well as carrying the susceptibility to malignant hyperthermia. The good news is right here. In recent years, the MH-related mortality has decreased to 10% when it used to be very fatal. We have better drugs and better understanding of the pathophysiology And so we can do more about it more rapidly when it is recognized. So what do? Well, as soon as the reaction is recognized, the first thing is for anesthesiologists, nurse anesthetists to turn off all the volatile anesthetic agents. And if succinylcholine is being used, stop using succinylcholine at that point. We don't do much succinylcholine drips anymore, but many years ago, that was a good technique for muscle relaxation for certain surgeries. It's just, instead of using non-depolarizing muscle relaxants, put a very dilute succinylcholine solution in a bag and just drip it little by little. When the patient develops malignant hyperthermia, the first thing is turn off not only the inhalational anesthetic, but turn off any air-oxygen mixtures or nitrous oxide and oxygen mixtures. Hyperventilate with 100% oxygen at high flows. Why high flows? Well, we want to prevent rebreathing of the gas. One thing that I stress to our anesthesiology residents a lot of times is that anesthesia machines are designed to conserve the traditionally expensive anesthesia gases. So the system is designed to recycle those anesthetic gases and recycle the oxygen even, absorb the carbon dioxide out of the expired gas, but let all the other expired gases be recirculated for inspired gases. Well, if you've got inspired inhalational anesthetic and you want to get rid of inhalational anesthetic, then what you've got to do is turn up the fresh gas flow rate so that you're dumping the inhalational anesthetic out to the evacuation system rather than letting it recycle back into the patient. This is a surgery conference. The important thing for the surgeons to work with anesthesiology is to know surgery needs to be stopped as soon as possible. This is truly a big life-threatening event, and it requires a lot of teamwork to properly manage the patient. There is certainly no way to say that surgery has to stop immediately. Sometimes you're in the middle of something and you've just got to do some tidying up before surgery can stop, and we recognize that. But we do need you to abort surgery, close up as quickly as you can so we can get this patient out of the operating room to an intensive care unit bed as soon as possible. And we need additional personnel to help. Well, I'll get into why we need additional personnel to help in a minute. But one of the important drugs that has come about is dantrolene. Dantrolene is the treatment for malignant hyperthermia because dantrolene inhibits calcium release from those sarcoplasmic reticulum stores. It antagonizes the Ryanodine receptor so that basically the plug on the sarcoplasmic reticulum closes back to keep the excess calcium sequestered in the sarcoplasmic reticulum to lessen the excitation contraction coupling that happens with the muscle cells. And I don't know if anybody's interested in chemistry, but up here is the actual chemical structure for dantrolene. So it's widely used in spasticity management before we recognized that it was a good drug to use for treatment of malignant hyperthermia. It was discovered actually by a South African anesthesiologist, Gayford Harrison, and was reported in 1975 in the British Journal of Anesthesia. And what he reported at that time was just use in pigs to help prevent the malignant hyperthermia or the similar kind of condition that occurred in the pigs. So this was a landmark article, and more research was done over the next 7 years, and its efficacy in humans was confirmed only in 1982. Before we had dantrolene available, the only thing we could do was give procaine to help settle down the cardiac arrhythmias that occurred with that. Turn off the inhalational anesthetic, give procaine. Procaine was not a real good solution because there was a 60% mortality rate even in animal models. So here's what dantrolene looks like. Here's a bottle of it. Dantrolene, 2 to 2.5 milligrams per kilogram is the definitive treatment. You administer it as a single loading dose as quickly as you can through a large bore peripheral IV. If you've got a central line, that's great, but typically you'll have only a peripheral IV. So dantrolene contains 20 milligrams of dantrolene per bottle and 3,000 milligrams of mannitol in order to provide an isotonic solution with the dantrolene. Excuse me, the vial is reconstituted with 60 milliliters of sterile water, not lactated ringers, not saline, not plasma light, not anything else. You want to use sterile water to dissolve dantrolene. It's got a pH of 9 to 10 when it is dissolved and ready for administration in the IV. Dantrolene does not dissolve well. If you've ever mixed dantrolene, you put water in it and you've got this nice yellow fluffy powder that floats on top of the water. And you've got to shake it like crazy to try to get it to dissolve. And then a little bit dissolves in the water and most of the powder is still floating on top. So you've got to shake, 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 shake. It takes a number of bottles of dantrolene to treat a malignant hyperthermia. It takes a few people in the operating room to do nothing else but mix dantrolene. You've got to have other people to help you with the cooling of getting ice packs. It takes a lot of people to deal with a malignant hyperthermia when it occurs in the operating room. So if you've got a 70 kilogram patient, it's a normal patient size, administering dantrolene means mixing up 9 vials of a fluffy yellow powder that really wants to not get mixed up. And not only do you need to give that initial 9 bottles of dantrolene, but you should give a subsequent dose of another 9 bottles about every 5 minutes up to 10 milligrams per kilo. So if you're starting at 2.5 milligrams per kilo and trying to get up to 10, that's 4 times the initial 9 bottles. So your total dantrolene dose might even be giving as much as 30 milligrams per kilo, not in the immediate situation of treating it, but over time, you may be giving a whole lot of dantrolene. So what you want to do is give enough dantrolene to treat the problem, turn off the inhalational anesthetics, and then continue giving 1 milligram per kilogram for at least the first 24 hours. You have 1 milligram per kilo Q, 4 to 6 hours. And you can also give dantrolene just as a continuous IV infusion of a 1/4 milligram per kilo per hour if that's more convenient. What about dantrolene's adverse effects? We've talked about the wonderful things dantrolene does for us. Dantrolene also causes sedation and other central nervous system depression type of side effects. So speech and visual problems may occur, mental depression, confusion, hallucinations, headache. You may even precipitate seizures. The patient certainly will be more nervous. Because it affects muscles, a patient may find that it's a little bit difficult to breathe. A feeling of suffocation may occur. There are rarely some hepatic side effects. Usually this is asymptomatic, just some elevations of bilirubin, elevations of liver enzymes, but very rarely fatal reactions can occur. The muscle weakness can persist for several days. Gastrointestinal side effects can be, well, as listed here, bad taste, decreased appetite, nausea, vomiting. The side effects, though, are more likely to be seen with a chronic use rather than with a treatment of malignant hyperthermia. Remember, as I said earlier, this was initially used for treating muscle spasm type of problems. So that's where you tended to see this, but there's a plateau effect. It doesn't paralyze patients, even though it's a muscle relaxing kind of drug, but there may be some weakness noted in the patient. Metabolic acidosis has to be managed. Again, this is where we need help from other people instead of just the anesthesiologist. The best thing is to start with bicarbonate, giving 1 to 4 milligrams, 1 to 4 milliequivalents per kilogram if you don't have blood gases available. And of course, if you do have blood gases available, then you can just follow the blood gases as to how much of a metabolic acidosis is present and needs to be treated. You want to have frequent arterial blood samples, coagulation studies, electrolyte studies, so you know how you're doing with managing the malignant hyperthermia and to help guide what other medications you need to give. The whole body cooling measures are very important if the core temperature is exceeding 39 degrees. You need to lavage any open body cavities. Hopefully the patient has a folded catheter in. You can put cold water lavage through that, cold water lavage through the rectum, put ice packs around the body surface, but wrap the ice packs so that the ice is not coming into direct contact with the skin to avoid any frostbite. IV, we certainly want to infuse cold saline. If the patient is trying to be kept warm, as we always do in the operating room, you've got fluids on an IV warmer, we need to stop the warmer and start infusing cold fluids. Myoglobin is formed, as I mentioned earlier, from the damage to the muscle. Myoglobin can cause kidney injuries, so giving a diuretic certainly helps that. And if you notice, as I said before, mannitol is already present in malignant hyperthermia, so that's going to help get that diuresis started. Expect cardiac dysrhythmias to occur. One important thing with cardiac dysrhythmias is that they usually respond to the treatment of acidosis and hyperkalemia. It's not the MH itself usually that causes the cardiac problem. It's rather the release of the potassium and the acidosis that causes the cardiac arrhythmias. So if you can fix that problem, you typically have also corrected the cardiac dysrhythmias. But it's very important to understand, do not use calcium channel blockers in a malignant hyperthermia patient being treated with dantrolene. In effect, dantrolene is a type of a calcium channel blocker itself. It's a little different kind. Most calcium channel blockers are going to affect the cytoplasmic membrane of the cell, not the cytoplasmic reticulum. So dantrolene is a calcium channel blocker of the sarcoplasmic reticulum inside the cell where the huge release of calcium is coming from. But calcium channel blockers can cause cardiac arrest and don't treat the malignant hyperthermia problem. They work at a different site than the Ryanodine receptor on the sarcoplasmic reticulum. Expect hyperkalemia to occur. Peaked T waves may be the first sign of hyperkalemia, even before you get lab values back. So if you start seeing those EKG changes, treat those EKG changes in the standard way that we normally would do, with hyperventilation, giving sodium bicarb, giving glucose and insulin to help drive the potassium back into the cell, and even giving additional dantrolene also will help reduce the potassium release from those cells. We have a new drug, and that's one of the nice things about this. It's a new drug, and it's not exactly a new drug. Ryanodex is a new drug, but it's actually still dantrolene. It's just a new formulation that contains 250 milligrams of dantrolene in one vial and requires only 5 cc's to dissolve. Where I mentioned to you earlier that dantrolene is really, really, really hard to dissolve. Ryanodex, on the other hand, dissolves instantly. It's 250 milligrams in one vial rather than the smaller amount. So basically, in most patients, we only need one small vial or maybe 2 vials to treat the initial malignant hyperthermia. This has been a huge help. The problem with Ryanodex actually is that it's a fairly new drug on the market, and as all of us know by now, new drugs are very expensive. So last I heard, I think one vial of Ryanodex was about $2,500. So we have to handle that carefully just because of the huge expense. But if you've got an MH episode, by the time you mix up that many bottles of dantrolene, you're coming up to just about the same price anyway. I think it's more in the $1,700, $1,800 neighborhood. Ryanodex helps us not have to have so many other people to at least mix the drug. And like dantrolene, since it is a different formulation of dantrolene, repeated treatments often are necessary. Again, I can't stress enough, as I did before, surgery needs to end as quickly as it's practical. and get the patient over to the intensive care unit. We need to get them out of the operating room where they're being exposed to inhalational anesthetic agents. The patient's temperature should be continually monitored. The patient may need some sedatives or hypnotics just to keep them comfortable. They may not be needed at all. Certainly blood needs to be continually collected to assess electrolytes, acid-base status, coagulation parameters, to keep that patient as healthy as possible. Venous and arterial blood gases need to be collected at least until the pH and potassium levels start getting more normal. A Foley catheter is very helpful to have in place to monitor urine output volume and also to serve as a real quick check for any myoglobin in the urine, because that is just so obvious. What do you do after surgery? Well, if a patient's had malignant hyperthermia, there are a few things that we should do. They should be advised avoid malignant hyperthermia triggering agents in any subsequent surgery. They should know what's happened so they can tell, especially anesthesiology personnel and any emergency personnel who may respond to any problems. If you've got someone who has had a malignant hyperthermia episode, it's likely that other people in the family will also have it because it's a genetically inherited problem. So family members need to be informed, and their personal physician should be informed so they can avoid any future risk from this. Refer patients with a malignant hyperthermia event to a malignant hyperthermia testing center for further evaluation. And you can look at mhaus.org or go to the Facebook page, which is mhaus.malignant.hyperthermia.association.us for further information and help with how to manage the patient afterwards. What about documentation? Well, it's really, really helpful to give the patient a letter letting them know they're susceptible to malignant hyperthermia, put a copy in the anesthesia records, and those patients can even get a medical alert bracelet, since this can be a life-threatening event. And that medical alert bracelet can also be obtained from the Malignant Hyperthermia Association of the United States. The 24-hour hotline for MH emergencies is a good number to keep handy for when this may unexpectedly happen. Sometimes it's hard to remember all the little details of what we should do to manage the patient as well as possible. Personally, now that we all have cell phones, I have this phone number in my cell phone so that I can call them very quickly if we get into any kind of MH crisis and have any questions about how to handle it. MH testing. Let's talk about how you actually do MH testing. There is something called a caffeine halotene contracture test, which is very sensitive. The nice thing about it is virtually anybody who has a risk or susceptibility for malignant hyperthermia will be detected. There's also a genetic test. The genetic test cannot currently replace the caffeine halotene contracture test because it detects only about 30% of the patients at risk. Now, here's the problem, though, is that the caffeine halotene contracture test is really done only at 5 very specialized centers that test this. The nearest one to us is Wake Forest University. There's also Toronto, Uniform Services University, Health Sciences in Bethesda, Maryland, University of California in California, and University of Minnesota in Minneapolis. There's only 5 MH testing centers for the caffeine halotene contracture test. There's only 3 genetic testing centers, and of course the closest one to us there is the one in Atlanta. The medical, I keep hitting that wrong button, sorry about that. The medical neurogenetics in Atlanta does genetic testing. Now, let me just describe the surgery for malignant hyperthermia testing. I actually have been involved in this in the past because during my residency I was at Walter Reed Army Medical Center, and that basically is associated with USUHS. We had a number of patients. Walter Reed was considered an MH center, and patients would come in to have the testing done. Well, the way you test for this is Obviously, you can't give them any inhalational anesthetics, but you've got to provide anesthesia to get a strip of muscle. That strip of muscle typically comes out of the leg. So what we would do is we would first make sure that we did not have any vaporizers on an anesthesia machine that might accidentally be turned on. We would do the surgery typically with spinal anesthesia. Get it nice and numb from about here below. The surgeon can make a little incision, typically in the back of the calf, take a little strip of muscle out, and immediately send it over to USUHS in Bethesda, where they do the caffeine health and contracture test. Now, what that is there is the muscle strip is placed in a bath that has basically it's held on either end, or it's laid across sensors that can tell how much the muscle is contracting. And then in that bath, they would put some halothane into it. And the bath contained caffeine because we knew that caffeine would accentuate the muscle's reaction to the halothane it was being exposed to. And essentially what they do is they just measure how strongly that muscle contracts to that in response to being exposed to halothane. The problem is, to do this, you have to get the muscle to the testing very quickly after it is excised from the body. Therefore, we cannot here take the muscle strip out and send it off to be tested. You have to send the whole patient to the testing center in order to have it done. Now, while I say that, the genetic testing is quite different, because you can simply take a blood sample and send the blood sample to them. So you don't have to send the patient necessarily to the genetic testing center, but you do have to send them to the health and contracture testing center. The health and contracture testing is much better, much more definitive. The genetic test is probably best to use for a relative of the person who's had an MH episode. If you know that they have had MH, you can send that individual's blood to the genetic testing center. If they come up positive to say, yes, this is one of the genetic conditions that we can test for, then it's worthwhile having the relatives send in blood samples so that they can tell whether they are also susceptible to MH or not. Now, what's the genetics of MH? We talked all about the expression and what we see, but MH and central core disease are both found on the Ryanodine receptor gene, the RYR1 gene. And changes in that gene account for about 70% of the MH cases that we see. The weird thing is there's no single genetic mutation that's responsible for MH. There's over 60 known mutations that may cause MH, and about 30 of those have been absolutely proven that those mutations are associated with MH. So patients who have central core disease are likely to be MH susceptible, but not necessarily MH susceptible. Relatives of an MH patient, again, are likely to be susceptible, but not definitely susceptible. MH has an autosomal dominance inheritance pattern. So here's the chances of somebody else having an MH problem. If they are the child, parents, or siblings of an MH index case, the others have about a 50% chance. Aunts and uncles have about a 25% chance, as do grandchildren. More distant relatives have a much less chance of malignant hyperthermia. And that pretty much concludes what I was wanting to explain to you this morning about malignant hyperthermia. And here are just a few of the references. I could probably have put up pages and pages and pages of references to malignant hyperthermia. But these are some of the articles that are certainly very well recognized as describing the MH situation. This again, the Harrison, this is one of the original classic papers on malignant hyperthermia when it was recognized. And with that, I'll say thank you for having me here this morning. You know, it's a very special occasion when you can get an anesthesiologist in a jacket and tie. So thank you for the opportunity to speak to you about this problem. Any questions?
So, I'm in the middle of the case, and all of a sudden the patient starts going down the throat. I've got a couple options. I could suddenly make that a damage control case. Means the abdomen is left open. Which means I got to come back in about 3 days.
Right.
Which is better?
Well, leaving the abdomen open at least enough time to help irrigate with cool fluids is real helpful. If in that situation, what we would like to do is get things under control in the operating room. Of course, as soon as we recognize that we're going to turn off inhalational anesthetics, we're going to have to go with an IV anesthetic technique. We may be able to use some nitrous oxide, but if you're in the belly, you probably don't want us to use nitrous oxide because it's going to cause the intestines to swell and make it more difficult to close. Minor point, of course, but we always think about those kind of things in anesthesiology as well to try not to make your life any more difficult than it has to be.
I can use the active closure.
Right, right.
Say that I got
Whatever you can do to finish up what you've got to do to keep that patient stable as quickly as possible is what we need to do. We certainly have to recognize that we yell MH, you can't just drop everything immediately. You've got to continue your surgery to get things under control enough to where you can close up so we can get the patient out of the operating room to the intensive care unit. Why do we want to get someone out of the operating room to the intensive care unit? Well, there's a couple of reasons. Number one, ventilators on an anesthesia machine are getting more and more sophisticated. However, they're pretty simple devices when you get right down to it. And an ICU ventilator has much more capabilities than any ventilator on an anesthesia machine. So an ICU can do more with it. Secondly, in an operating room, we don't usually think about it, but we have some traces of waste anesthesia gas floating all around in an operating room. That's why there's a number of turnovers of air in an operating room to try to keep that waste anesthesia gas that's just in the entire room to the lowest practical level that we can get it so that you and I aren't being exposed every day to a higher concentration of waste anesthetic gas. When you turn the anesthesia gas off on the anesthesia machine, we can ventilate of no anesthesia gas, but we still honestly need to get the patient stabilized, surgery finished, and get them out of there to intensive care unit as soon as it's practical. Meanwhile, while the surgery is continuing, anesthesiology is going to be working on trying to get the dantrolene in, get everything stabilized. The other thing is, if you're there and one person can close the belly and another surgeon can break out and help us with getting ice packs, getting dantrolene mixed, assuming we're still using dantrolene instead of having Ryanodex upstairs. And the good news is we actually do have vials of Ryanodex here in pharmacy, but we've got to get them up to the operating room. We don't keep Ryanodex on an anesthesia cart. We don't keep dantrolene on an anesthesia cart. We've got to get that from the workroom. And typically what we get is, a big box of like 30 vials of dantrolene to bring into the operating room. So once MH is recognized, it takes a few minutes to begin treating it, except for turning the anesthesia off. And so that's why we need to try to stabilize things. But again, as I said, remember, we may also be getting into a DIC situation, which may further complicate your lives as a surgeon. So do what you can to help us is really the best advice for that. Okay, any other questions?
What kind of recovery do they make? Do they return to vigorous life, or do they
Yes.
have early congestive heart failure?
It can be any of that. Most of the time, caught early and treated early, patient will return to just normal life and just have a MH band on their arm to warn anybody in the future. Most patients now, maybe not so much 30, 40, 50 years ago, but most patients now survive malignant hyperthermia and return to a fairly normal life. Anybody else? Again, thank you very much. Enjoyed discussion with you today.